Welcome back to the postpartum years. Today we are going to be covering part 2 of tongue ties and how it impacts mom and the baby. And we'll dive in a bit into the research as to what's been done, what needs to be done as far as research goes, along with tongue ties and many other topics. Being my nerdy self, I went to the Academy of Breastfeeding Medicine to see what areas that they found needed more research, which there's been crap for research
Oh
in
yeah.
this field.
And
So,
that's part of the controversy.
right. One of the things they said was a clear definition of what a tongue tie is because there isn't. So that's part of the craziness with, yeah, somewhere
Yeah.
between 4 and 20% of kids have tongue
Yeah.
tie. Yeah. Because there isn't that clear definition of what is a tie. And we will get into that as well. Um, and then how much needs to actually be cut for optimal breastfeeding is
Yep.
another area that needs to be researched. Identification of the optimal surgical instrument and technique, because the one that's been done the most actually has been scissors.
Yep.
So that is technically the gold standard because it's been done the most.
Yep.
Um, so all of those dentists out there that are using lasers and love their lasers, love their lasers. And after seeing, uh, a tongue tie release using one of those lasers, I understand why they love those lasers.
Yeah.
They had a nice
I've
little happy
seen
baby
one
there.
scissor release and it was messy, bloody, and the baby screamed the entire time.
That's what I was picturing, even with the laser, but zero blood, zero pain. Yeah. When the swelling kicks in a little bit later, yeah, there'll be some discomfort for
Yeah.
sure, but kind of comparing surgical instruments and techniques, it still needs to be researched. And then
Yep.
the long term outcomes after the tongue tie or lip tie releases on effectiveness and duration of breastfeeding. So, you know, is that baby able to breastfeed better? And I hope if they're going to be doing this research, they're doing the outcomes on those babies that are getting it within the first month
Yep.
versus babies that are getting it at 4 or 5 months, because
Yes.
that's going to be a completely different outcome. That baby's not going to be able to automatically kick into the natural reflex, a pattern of movement.
There is a myth, I feel like, in the lactation world where we feel like it has to be completely released or it needs to be redone. I have seen babies have some reattachment happen or it wasn't cut very deeply, and mom stopped having breast pain and nipple pain, and baby started eating better and gaining weight well. And I'm a middle of the road type of person. I don't like either. I don't like extremes. I just don't. I feel like that's just me in my personal life and in my professional life. And I feel like there's no need to put baby through another procedure unless it's absolutely freaking necessary. Because even though it's a simple procedure, it's still a procedure. It still has risks. There's still pain. Also, doing multiple procedures on a baby can create oral aversions where they just stop eating. And I have worked with babies that have just stopped eating anything, breast or bottle. And, if you want to see like how freaked out and stressed out a parent is, show you a diet where the baby's just not eating anything at all. Super scary and super
Hmm.
stressful. And you got to get really creative to get that baby to feed. And you have to really take the pressure off. And there's a lot of pressure, again, like I said, from like the pediatrician, like the baby has to gain weight, the baby has to gain weight. I'm like, yes, I know, but I just want the baby to eat. And so currently, if the baby's gaining like suboptimally, that's okay. We're building to be able to increase in volume. We're working on it here. um the identification of the optimal surgical instrument. There was a presentation I listened to and watched, a webinar from a woman in India, and she had heavy bias on scissors for release. She said that actually the aftercare and the healing of the tissue was way better with scissors than the laser. and that somehow, and mind you, I don't know how you do this with the infant, that the pain was less. And I think the research that she quoted was with how much usage of pain medicine the parents used, not necessarily reading babies' minds. And so baby, on a scale of 0 to 10, how much pain are you in today? Like, that's not, we can't do that, unfortunately. But here's the thing, is that the aftercare for scissor procedures and laser procedures is often different. And so I feel like with scissor procedures, most of the time they're not recommending any kind of stretches to prevent reattachment. It's usually much shallower. It's usually only done with just anterior, and it's not as deep or as thorough as a laser procedure, which honestly, I don't really know which one's better, Mary Ellen.
Hmm.
Do you know what I mean?
Yeah.
Like, I know
There
what
needs to be some
clinically
research.
we need a lot more research on this topic so that we can like resolve the controversy, basically. And so I feel like if you're constantly poking, doing these active wound management stretches for the tongue or the lip, that baby is going to be way more fussier, and you're going to be more inclined to give them pain medicine
Hmm.
than if you're not doing anything at all. Right.
Right.
So like I said, like, there's a lot. Unfortunately, this is really, really gray, and there's so much more nuance, and there's so much more need of research that has nuance and really understanding of all of the levels and the complexity of the issue, and not just saying yes or no, black or white, good or
Hmm.
bad, this is the best, that's the word. Like, we need a lot more nuance in the research too. Um, the long-term outcomes, once again, working in a hospital, I now realize, and also having worked with some medically fragile infants that had long hospital stays, medically, they freaking love breast milk. They love breast milk. They know, they've measured it, they've tested it. They know that it has, 350 plus things in it that are amazing, that do amazing things for the body, that do amazing things for this, and amazing, like, they love it. They love breast milk. What they don't really like, or what they don't really love or know how to support, is breastfeeding, because you can't measure it. You can't really it's hard to test. There's not like a, baby doesn't have a empty full gas gauge, and neither does the breast. So they don't know what's going on. They don't understand it. They don't trust it. And so they don't recommend it or reinforce it. Um, but to me, coming from my, education and viewpoint, latching and lactating and connecting and direct feeding baby at breast is the physiological normal thing to do. It's what our bodies are supposed to do. The mom's supposed to lactate, the baby's supposed to eat at the breast. That's the normal thing to do. So when we don't have that, anything else is a compensation. So
Hmm.
exclusively pumping is a compensation. It's still breastfeeding, and and to me it's a hell of a lot more work. And sometimes I've heard people say, like, oh, it's the easy way out to pump, and I'm like, no, it's not. Like, when breastfeeding works, it is for the lazy. You don't gotta wash crap. It's not like, it's so much easier, right? But the value for pediatricians, for neonatologists, for OBGYNs, for doctors in the medical field, is the breast milk and not the breastfeeding. And what I feel like we need, like, some qualitative research on, because I believe breastfeeding, and there is research that supports this in clinical knowledge and experience, it shapes the way that the face is shaped, bottle versus breast. Continuously using jaw muscles versus continue using, you know, lips, it changes the way the face develops.
Hmm.
It changes, and the way the face develops can change the way that everything else develops,
Right.
right? Because, like, the fascia is like all the way from here all the way down to your toes, right, Mary Ellen?
Right.
So
Right.
it's like, what, and also most women, when they breastfeed on each side. And so there's bilateral movement. So babies are getting integrated bilaterally. And there's a lot of stuff about like integrated primitive reflexes and um, being able to cross midline that we're seeing in some of these kids that are neurodivergent. And when you, how many times have you switched sides when you're bottle feeding a baby? Most
Yeah, a
people
lot of
don't.
people are very right-handed, so that baby goes in the left arm and the bottle goes in.
Yes. Yes. I consider myself an excellent bottle feeder. I feel like I'm really good at it. And I struggle to switch sides. I struggle to go, you know, back and forth to different sides. But I also know that like neurodevelopment and being exposed, like if if you're constantly in one position all the time, having like the motor planning and things wiring in that one position, we're losing something. We're
Hmm.
losing that ability to cross midline. We're losing that um, symmetry of the body, getting the balance of development. Yeah. So it's like when we just take and so in the hospital that I work at, the neonatologists, their recommendations is to pump and bottle feed and wait and see if things get worse and work with lactation and not to intervene at all because it's overdone. People are making money off of it. At one point, I feel like I might develop enough rapport with one of these neonatologists that I work with to say, have you ever done that while you're sleep deprived, while you're learning how to feed a tiny human? Have you ever done that? It's way easier said than freaking done. And also, what are they missing out on?
Right. Are you looking at the function down the road?
Yeah. And they're not. The pediatricians and the pediatric specialists that I've had, very frank conversations with, they're like, all we're trained is that the baby has to gain weight. And if the baby's gaining weight, everything else is not important.
Hmm. It comes down to time and, what can they manage in that little bit of time?
Yeah. And the neonatologists in the hospital, they're not trained to assess, they're not trained to release. So they're like, we just hot potato these babies.
Yeah. Well, and they're worried about the baby's survival.
Yes.
It's in the NICU. They're worried about survival.
So I will have to say, like, as much as I have, kind of like a issues with sometimes how things are done and managed, the neonatologists that I work with in the hospital are really, really good at keeping babies alive. And I kind of want them to keep doing that. Let them focus on that. But then also respect me when I have concerns about feeding.
Looking at the whole picture, not just at that baby in NICU, but what about further on down the line?
Yes.
So, looking at the whole picture, say we have a baby that's been discharged from the hospital and they're having issues with feeding. Well, we need to do a full feeding assessment and rule out what other functional issues might be happening.
We have had experiences where there or parents did not want to release, or where I refer to you to get a clear reading on whether or not it was tension or fascial restrictions in the body, or if it was actual something that needed to be cut.
Right.
And we have seen insane things happen with your body work and with other providers' body work for that matter, not just
Hmm.
you, like other people that I've worked with. It is there's a lot more going on than just tongue tie, even when there's a tongue tie, and
Yep.
even when it might need to
It can
get
be
cut.
both.
Yes, two things can be true. It could be both. Um, so oversupply and a fast milk ejection reflex can make a baby retract their tongue and gum the nipple and only be able to stay latched to the tip because they're just trying not to drown. And they learn really quickly, oh, if I like hold the nipple in just this position and I compress right here, I can manage the flow. Cool. I'm going to keep doing that. Right.
Because I like
Uh,
breathing.
hey, you know my line is babies are going to choose to breathe over eat any day of the week and we want them to. Like that's a great thing that babies decide to do. Like, yes, go baby, choose to breathe, because we can work on feeding issues, but we can't, if you stop breathing, we're in trouble.
Yeah.
So feeding no
Nothing
longer
else matters.
matters. Yeah. Like, you need to get admitted and get an IV, and then we'll deal with feeding problems again, right?
Yes.
So like that fast milk ejection flow, oversupply, same thing with reflux. If every time they open their mouth and maybe they have a food sensitivity or allergy and their esophagus is inflamed and swallowing hurts and causes them pain and discomfort, or is about to because it's about to come right back up, they often, again, retract their tongue and get very, very tense, then lock it into place. And it will often look like a tongue tie. But again, if that baby is gaining enough weight or the baby's safe and stable, if we can fix the reflux, sometimes it's not a tongue tie.
Right.
Sometimes it's simply the reflux or it's simply the oversupply. Also, and I always have a hard time saying this word, plagiocephy.
Plagiocephaly.
Plagiocephaly. Sorry. Like, I really probably should take a Latin class to learn how to say medical words better and practice more. But plagiocephaly, um, having any kind of misshape of the head is going to push and pull on and not allow the jaw to move and the tongue to move in the same way. Or like torticollis, like that, at the very beginning. Yeah,
Yeah.
torticollis.
Okay. Yep.
Um,
The head being stuck to one side or not wanting
yes.
to turn all the way to the right or to the
Or,
left.
and here's the thing, and you and I see this, it doesn't even have to be that severe to affect feeding. It could be like just there's a preference. Baby can move, but it's often when they do move, it's kind of like that. It's not like a smooth
Yeah, there's no
track, right?
fluidity to the motion.
Yeah. That can pull on the hyoid bone, the sternocleidomastoid or the occiput can put pressure in ways that it doesn't allow the base of the tongue to function properly. And releasing that and resolving that, then you can actually see, is there a tongue tie or was that a big part of the problem? And that now that that's released, now the tongue can function optimally, whether or not you see a freaking frenulum or not. Because I do agree in the controversy that it is overdiagnosed and over released. I really, really do. I agree with that. But then I also know that they freaking exist and sometimes they just need to be cut.
Right. Right. And on that note, there are also times where they should not be cut. So we've got a whole list of things here that are times where it's not okay for a baby to have a tongue tie release. So I know you've had one in particular where the baby had an oral aversion. So they didn't
Yes.
want the breast, they didn't want the bottle, they didn't want it. I mean, there were so many things that this baby had been thrown, so many different things that were thrown at this baby, and she hated all of them. So to do a tongue tie, yeah,
She was barely interested in feeding at the breast. So this baby had had a tongue tie release at 2 or 3 weeks. It either reattached or it wasn't cut as completely as a different provider would have liked. And the mom was very anxious and aggressive with trying to get baby to take a bottle. She had seen, I think before she saw you, like 5 feeding people, which I'm not
at
quite sure if they were
least.
IBCLCs or OTs or SLPs or a
I
combination
think
of
all of the
all
above.
3,
Hmm.
all of the above. And I finally was, you referred this family to me because like I love me an anxious mama. Um, I love working with anxious moms and helping them to figure out how to calm down and regulate their system while working with feeding issues. Um, and this baby, we were finally getting the baby to eat solids. And so they like solids and breastfeeding was possible. The baby was struggling with something called a honey bear, which is like a little like straw cup that you push. It was not sucking. And another lactation consultant that she was actually seeing while she was seeing me heavily recommended, based on a virtual appointment and pictures, that there was no way that this baby's tongue would ever function and baby would ever be able to suck on something unless the tongue was released completely and revised. And actually, like, so when a tongue tie is released, that's the initial cut. It's not a revision, it's a release. And then if it's done again, then it's called a revision. Okay. But so this other provider insisted that the baby's tongue would never function optimally, that that baby would never learn to suck on anything properly, and would have, forever have issues if that baby did not get a revision, a second procedure. What I know is that that mom was still hella anxious and was only able to chill out when it came to solids, even trying to get this baby to take a sippy cup, which when I was there and I was chill and I was letting the baby be in charge of it, this was like a 5-month-old baby. So like an older baby. When I was letting her be in control of it, she would latch onto it and she'd suck a little bit. But when the mom would do it, she'd force it, force it, force it. And I'd be like, no, 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 don't force it. Um, and it became like a power struggle with the baby. And the baby was starting to get burned out on the sippy cup too. So, like, all of these other methods that this mom had tried, other than breastfeeding, was causing a severe oral aversion. And like, baby was just not going to eat. And so I spoke with a provider that assessed them, somebody here locally that does frenectomies. She was like, what's your take on this situation? Like, what do you think? Like, I'm hearing from this other provider, it has to be done, it must be done. And I'm just like, I don't think this other provider has assessed how anxious this mom is and understands why the bottle never worked, why the honey bear straw thing never worked, and how the only way that solids is working is because I've gotten this mom to chill out and let the baby be in control. And if the baby's not in control, it's not gonna, like, the mom can't feed the baby other than breastfeeding, like, without forcing it. It's just not possible. So when I went to so here this mom is super confused and wants the dentist to give a clear answer, black or white. Is this necessary or is this not necessary? Give me the answer. I need the answer. Where's the answer? And so after talking to me, she was like, I am choosing not to do the procedure because I think that, it can wait. And like, maybe in the future when the baby's older, maybe we'll revisit it if you're still having issues. Right. And the other provider got very upset and was not happy with me seeing this person and or the mom and or the dentist for not doing the release. I based it out of genuine concern this other provider had from like what she knew and what she thought it needed to happen. Well, when I discussed everybody's viewpoints and everybody's sides and the controversy of everything with the mom and the dad was like, we're not doing it if there's a chance that my baby might just stop eating. So no, it's not happening. We aren't doing it. I don't give my permission to do it, even if the mom wants to do it. We're not doing it because I've seen what's happened with the bottles, with the this, with the that, and no, we're not doing it. Because he was seeing what I was seeing with the
Hmm.
anxiety and the
Yeah.
forcing and the pushing, and knew that that wasn't, that would continue. And especially if this mom felt like she had to do the, post release active wound management, she was going to be poking and prodding in that baby aggressively, and then I knew that that baby was going to stop eating if
Hmm.
that happened. Or once again, I didn't have a crystal ball, but the risk, just the simple risk of that being a possibility for this infant, wasn't okay.
Right.
Yeah.
Right. So other issues where it's unsafe to release, if the baby has certain medical issues, they may have a cardiac issue or
Yep.
something else going on. They may have airway issues where they have difficulty keeping their airway open.
Yep.
Definitely not safe. Um, the baby may have pain issues, they may have tongue guarding, or just really not thriving, and not thriving because they're not eating, but just other reasons. So a lot of mostly medical reasons why it would be unsafe to eat. But I wanted to point out that oral aversion um, is different from the others, where the others are more medical issues, where oral aversion can be a consequence.
Yeah. And honestly, I've seen it with infants that parents weren't being forceful and they weren't hella anxious. And the trauma of having the procedure was too much for the baby. And the baby like shut down and was like, nope, mm-mm, nope, mm-mm. Something to also say that I think that people don't know about when it comes to the release and like the after process of the healing, babies will have increase in saliva because the mouth is trying to produce more saliva to help the wound heal faster, I think is the mechanics of
Hmm.
that.
Yeah.
Um, and if the baby has airway issues and fluids that go in the baby's mouth are going in the wrong places, and then you add more saliva, danger, danger, not good. That's problematic. And so that's one thing. I've also worked with a family that had laryngomalacia, and that baby had tongue guarding, and it presented like a tongue tie. And but it was not a tongue tie. It
Hmm.
was the laryngomalacia, and it was the tongue retracting to protect the airway
Yeah.
and mediate the flow.
Yeah.
And slowing down the flow of the feed at bottle and breast consistently, that baby thrived, was like 13 months old, and had started solids, was doing pretty good with solids, occasionally would gag and spit up randomly, but not with any like consistency. Usually, honestly, no, actually, mom said like whenever she got any kind of congestion, it would make the breathing and the laryngomalacia worse.
Thanks for joining us for part two of tongue ties, and we still have even more to cover. It's amazing how complicated this particular issue is. But join us next week for part three of tongue ties. See you then.